Toe assessment. Danny, come on up. Good looking secretary. This is his favorite thing. I put my hands on him. He likes it. Yeah, he's weird that way. Now, when we look at this cranium, no, I'm teasing. On a head-to-toe assessment, there's a number of things. We're going to just start at the head. Good looking Brad Pitt look-alike here. Yeah. And it shows us certain things. I said battle signs. Poor guy's battle fatigue. That's just bruising behind the ears. You'll see a little discolorment, almost a yellowing, or raccoon eyes, which he almost has anyway. Did you get some sleep last night? Oh, a little bit. He's a dynamo here. So they might look black and blue, like somebody punched you in the nose. Sometimes you'll find a little bit of a colored, or not colored, a non-colored viscous, almost like an oil coming out of the ears. And that's cerebral spinal fluid. That's not a good thing. That's that fluid that's in your brain that keeps it balanced. Okay, back on the head. Is there any breathing issues? Is there anything blocking his airway? So we've got his eyes. What about his eyes? What if one pupil's big and one pupil's small? Is that normal? Got a story about that. My wife was outside. She comes in and looks at me, and she's got one eye like this and one eye like this, one pupil. I'm like, oh my God. Because you know what? I was thinking about that with my daughter when she got hit by the car. That intracranial pressure will drive the brainstem down through your spinal area here. And that's where the problems come. So she comes in, she's got one big eye, one little eye, and the first thing I think about is up that insurance policy because I'm going to be rich. No. I'm thinking... So anyhow, I'm like, what in God's green earth? Would you fall down? Did you trip? What happened? I don't know. Look at this. I'm like, wow, you're freaky. Besides the point, you're freaky. But and so I'm like, what happened? And I'm trying to get information. I'm on the phone because I'm thinking she might have a bleed inside her head. Maybe there's a bleed. Maybe it was just a, pressure building up regardless. Maybe she didn't hit her head. Maybe she blew a valve up there or something. I'm not a brain doctor. But, so I'm asking, and she goes, I go, you've been working outside? Yeah, I've been working in the garden. Okay, working outside. I go, have you done anything? Well, I sprayed the plants yesterday. What did you spray them with? I sprayed them with this funny thing that makes one eye go like this and one eye go like this. Thank you. I hung up the phone from the hospital, the eye doctor. I go, just leave me. No. Just, go outside and go back to what you're doing. But it was weird because now I'm put into this phony situation. It's not real. It's not like a traumatic event. But what led up to this? You're doing your investigation. You're trying to get that information. It's like when you have children. What happened? How did you get that bat stuck in your neck? So you're trying to pull these things together. So back on the head, breathing, the eyes will tell you something. Cerebral spinal fluid, darkening behind here. Then we go down to the neck. Is there any disfigurement on the neck? When we palpate, do we feel a bump or a rigid? Is something not feel normal there? It's funny because I was doing CPR on this one old guy in Southgate when I was younger on the job, and his neck wouldn't, I was trying to adjust his head. Well, he had 4 of his things fused, but he had a heart attack. But we're trying to get his head to go. It wasn't going to work because he didn't have the flexibility inside there. So the neck, and then we come down to the shoulders, clavicle area. Because the clavicle will get broken. Those bones get, they're pretty strong, but they will break. So is there any issue with that? Because if there's an issue with that, that's kind of close to his heart and his lungs area too. Maybe there's more traumatic event that's happened to that. Shoulders, and we come down to the chest, and we're looking, and we're seeing, the chest is going to tell us a few things. Is there a rise and a fall? Is there a good air exchange? Realistically, because that's what we're looking. We're looking for breathing and circulation in the whole body. And is it continuous? Breathing and circulation, is it continuous? So we're looking at his chest. Is one side blowing up and the other side not? When we look at his neck, we call tracheal deviation. Anybody heard of that before? Tracheal deviation? It's the shifting of the trachea to one side, and then call it indicative. Well, it's a nice word. I like using that word to make me feel smart. It's indicative of pressure from one lung building up, and there's a pleural cavity, and it pushes over on the other, and it limits the air supply. and it fills up this area, and it pulls your lung over, it pulls your trachea over, and you look at it and go, God, this trachea, our breathing area is pushed way over. And you go, they've got a problem inside. And that's where we do a needle thoracostomy. Have you ever done one?
Well, that's a tension pneumothorax.
Tension pneumothorax.
That's different. That tracheal deviation is a late sign. And
Late
your
sign.
trachea is your air pipe, right? Okay, so you know that. That's the air pipe, and then the other one's the esophagus. That's the food pipe.
Okay.
And you don't want to get anything in that. But yeah, no, that's when you have pressure in one side, and it'll cause that tracheal deviation. But it's
The movement.
or it could be a spontaneous pneumothorax.
Oh,
Air inside the lung, but it's not getting out of the lung.
It's
So
getting in
they
there.
teach us to put a needle inside the lung, and it lets the air out, because it'll just keep building up, and then it'll push the heart over, do all these things. You can actually you can die from it.
Yes.
So is the pressure actually inside the lung, or is it like one of the sacs that line the lungs?
I think it is in the sac. I think. Do you know? It is in the sac, right? Yeah, and you're just trying to relieve it, and you're supposed to go over I think the third intercostal, your rib,
Look, you
basically.
smart people
And
here.
then you stick
Learning
the
all
needle
this.
in, and it pops out. And sometimes there's blood that accompanies it, and then you wrap it up.
But-
There's like a flutter valve that you want air so it can come out.
Knowledge is power in that aspect. In taking a medical class or something like that, you build up kind of an understanding. Can you do something about it? I don't know. Can you identify it? Yeah, maybe that helps you. Because first arrivers, got tracheal deviation, late signs. Yes.
And so do only paramedics do that, or?
Yeah, it's
Yeah.
not an EMT skill.
No.
And I was a medic for 7 years. I'm trying to think, because we see I get a lot of shootings. I think I did it one time when I was fairly new. It's like shocking somebody when they're awake. You guys know what that is? It's cardioversion.
Cardioversion.
So and it's not fun, because they're talking to you. Go, dude, it's going to hurt because I'm going to shock you right now, because you're in an unsustainable heart rhythm. And if I don't shock you, basically going to go down. But now we have this new drug. It's called the adenosine, where it gets you back into a normal rhythm, which is a lot safer, easier to use. It's really cool, because you see you're watching the heart monitor, and it's going, it's going funny. And you push this drug, and it goes flat for about 10 seconds, and then it goes normal again. So
So it gives a white guy rhythm.
Yeah, right, exactly.
I like it. It takes some.
Yeah, it's interesting. So yeah, it's just different. Yeah.
Shoulders, chest, arms. These bad boys. These are bad dudes right here. Okay, so we come down to the arms, and we're just palpating. Is there any blood deformities, any type of disfigurement of that? But we can also check on both of them. And what we do is we give it we call it we don't pressure on the same sides. I forgot. I'll think of the term in a minute. But we want to give it an offset pressure so that we can see if there is any break. Because if I just push on top of it, it feels good. But if I push a little sideways, then I can see if there is movement in there. Or I might hear it or feel it. Okay? So we come down. And what do we do when we get to the hands?
Will you marry me?
What do we do when we get to the hands? Cat? I like to squeeze my hands too. Because that's going to help us too. Squeeze my fingers. No. But we're going to go ahead and we're going to find out whether or not he's got good circulation. He's got equal grips. He can follow directions. Okay, so that tells us a lot as we come down. We can also do the Blanche test. He's got good perfusion in there. Okay, we've got the fingers, and they're coming back well too. Chest, arms, abdomen. We get this. We call this one not a 6 or a K. No, we come down to the 6-pack. Okay, and we palpate it. And you know what we're looking for? What do you think we're looking for? Rigidity? Any disfigurement? Any discoloration? Any tenderness? Any rebounding? Anybody's ever had a stomach ache, or a kid got hit in the stomach, or or catching their breath, those kind of things, you're going to go ahead and it's going to be an abdominal area. Who knows? It might be an appendicitis or something like that. But you're documenting, or somebody next to you is documenting it. So we're going to see if there's any extended abdomen. We're going to say, is that normal for that person? Pelvic area, as we come down to the pelvic, we're going to push in, and we're going to kind of push down. We're just going to see if that pelvic girdle was crushed. Now, that's more of a traumatic kind of situation. That's not something that's just going to happen, unless it's somebody older that slipped and fell, and maybe cracked their pelvic area. But for a pelvic girdle to be broken for an individual, that's a hard force, because that's our stability. Our pelvic girdle is a very hard rigid area on us. It's strong. You know, the Creator made us to where we could withstand